On the behalf of the College of General Practitioners of Sri Lanka, it is my privilege and honor to welcome two of our experts and all the participants for this important webinar on update on dive-in and hyperbaric medicine. In Sri Lanka, dive-in medical emergencies are apparently increased in number during the latter part of the past decade. The expansion of commercial dive-in opportunities, rapid development in the country following the cessation of internal conflict are the main facts lead to increase the dive-in operation in Sri Lanka. However, emergency treatment of dive-in medical illness reported in Sri Lanka is not satisfactory in comparison with the developed countries and even with the regional countries such as India and Pakistan. This is basically due to poor infrastructure development in the field. Currently, we have only one recompression treatment center, which is located at the Trincomalee Naval Base. Even though most of diving related illness are not indicated for recompression treatment, it is difficult to differentiate it from major life-threatening and severe dive-related illness like arterial gas embolism, type 2 decompression illness, without adequate clinical knowledge and experience in Sri Lanka. Therefore, as a primary care physician, we should have sound knowledge about the key symptoms and signs of dive-related illness. Aim of this webinar today to update our primary care physicians regarding initial approach of diving emergencies in primary care setting. Today we have two experts and they are going to talk on the different aspects of diving and hyperbaric medicine. I think this webinar going to enlighten you, educate you and upgrade your knowledge and improve yourself. This type of webinar facilitates all of about day-to-day management of diving related illnesses. End of their presentation, we will have a question and answer time session. You can direct your questions into chat box and then we can direct to the respective presenters. Traditionally, we are introducing two speakers. Now, it is my pleasure to introduce Dr. Heerath. Dr. Heerath is a graduate from University of Peradeniya. Then he was entered to postgraduate training and obtained Master of Surgery in the disciplines of General Surgery from prestigious Postgraduate Institute of India, Armed Forces Medical College. Further, he has trained in the field of dive-in and hyperbaric medicine from Navy Hospital, Ashwini, Mumbai, India. He is identified as eminent speaker in the field of diving and hyperbaric medicine. He had represented many professional training activities for divers and paramedicals who are handling diving casualties. Presently, he works as a Director Naval Medical Service in the Navy headquarters. He is going to take to us on management of diving medical emergencies in Sri Lanka. I invite Dr. Heerath to present his presentation. Dr. Heerath, please come forward.
Thank you, Dr. Namal. It's really a prestige to let me share my slides first. Nandan.
Technical difficulties with one of our lecture. Therefore, we changed little bit. We have done a little bit change with our presenters. Now, first presentations will be delivered by Dr. Dinesh Ariyadewa. Dr. Dinesh Ariyadewa is a past pupil of Ananda College, Colombo. He entered medical faculty, University of Peradeniya. After completing his MBBS degree in 2002, he obtained Diploma in Family Medicine in year 2008 from Postgraduate Institute of Medicine. He actively involved in distance learning program of the same field as a tutor of the Postgraduate Institute of Medicine. He was granted the scholarships to Second Military Medical University of the People's Republic of China in 2014, where he studied drive-in and hyperbaric medicine and conducted MSc research under the supervision of world-renowned Professor Dr. Viegang Siu. He has also written several international research publications on decompression sickness. He is a member of academic committee which developed MSc in military medicine at Postgraduate Institute of Medicine, Sri Lanka. Currently, he is reading for Master of Philosophy degree at Kothala Defense University. He serves as the acting Commodore Superintendent of Health at Navy Hospital, Trincomalee, and he is the responsible for recompression chamber treatment. Now, I cordially invited to Dr. Dinesh to deliver your presentation. Please,
thank you,
Dr.
Namal.
Yeah.
Welcome you all for our evening presentation. This is also related to the diving medicine. This is mainly the marine animal injuries, how you should diagnose and how you should manage. So my topic is management of dangerous marine animal injuries. So marine animal we can encounter in the waterfronts, and these creatures affect our lives in a various way. Some animals spread diseases like schistosoma, but I'm not going to discuss about the infectious diseases, but my interest is mainly the injuries and envenomation. So there are two types of it. As I said, injuries or intoxication and infectious diseases. So marine animal, they use their defense mechanism in their environment. Usually they are harmless. If we encounter them in a different way, that means if we accidentally step on them, if we going to handle them and making them very nervous, they may try to attack us, unless otherwise they are very harmless. So their mechanism of defense can be recognized as venom injection. That means they have various mechanism by bites or stings to inject the venom into the enemy or predator. The venom can produce various kind of reaction upon this victim, and it may that mean make the victim paralyzed or chase away from the place. Maybe that marine animal bite you if they get agitated. So it is one other way of their defense. Maybe they produce different kind of biochemicals. If they touch on your skin or eyes, they may produce irritable feeling. And other things are poisoning. Many of the time we eat the marine animal flesh, like fogu. There are sometimes highly poisonous to us. So this produce, they can produce allergic reaction, headache, abdominal pain, vomiting, even paralysis. Some marine animal defense mechanism consists of electric shock. For example, some electric eels, they have specialized uh, nervous tissue or muscle tissues that can produce electric energy, and that can paralyze the enemy. So that we can identify these marine animal attacks or damages in various categories that may make some kind of discomfort us, may need minor medical attention, or may need major or emergency medical attention. For example, you must have seen the shark attacks in various films, but I'll discuss later. Uh, these attacks may be very uh, deadly. For example, box jellyfish or Portuguese man of war attacks, that means envenomation, can produce kind of systemic envenomation and maybe lead to shock. So in Sri Lanka, we have very limited data regarding the marine animal envenomation or injuries. This data I took from Sunday Times about several years ago. That indicates very few numbers. For example, sea snake, sea urchin, but these data I am not sure whether they are correct. Anyway, we usually see significant number of injuries due to marine animal, mainly the jellyfish. We'll discuss each separately. So marine animal envenomation management can be categorized in the two tables. That means we can manage to prevent further envenomation. That means we try to minimize the spread of venom into the body, or we can reduce the pain. Many of the time, marine animal envenomation cause pain only. So these two type of management are the basic management we are having for the marine animal envenomation. So the prevention of further envenomation can be done via pressure immobilization bandages. That means we minimize the spread of poison, or maybe we can apply some chemical upon the area, or we can reduce the pain by denaturing the chemical that cause the pain. For example, some proteins produced by these marine animal cause the pain. So if we denature the protein by heat therapy, maybe pouring some warm water on the that mean wound or sting area, that protein will denature and stop the action of the protein. Or maybe we can use cold treatment as a soothing effect on the area. So, first we see this jellyfish stings. Sometimes we may manage this jellyfish sting very wrongly. In Sri Lanka, jellyfish attack come with the monsoon. The jellyfish usually wash toward the shore with the monsoon. For example, in the northeast monsoon, we mostly get the jellyfish attack in the December or January, and other part also during that monsoon. So these seasons we get mostly this true jellyfish type. It get a hood and the long tentacles, and they are encountered in groups, that mean in thousands. So we can see them most of the time because they are very colorful. Rarely they may be colorless, and other things. Unfortunately, they remove or they break their tentacles. That means long tail-like things, hundreds or thousands of tails from their body, and these tails float in the water. So I'll discuss this effect of these tentacles. We get not only the true jellyfish, sometimes we find this box jellyfish in Sri Lankan waters, and also Portuguese man of war type jellyfish. These two jellyfish bites are very deadly. In Sri Lanka, we have no exact record, but unofficial record says some deaths also has happened with this. So the tentacles, these tentacles consist of thousands or millions of small nematocytes. That means they are primary mechanism of the organism. Primary, that means primary, not very developed organisms. These genes, these nematocytes has a poison sac. So in the tentacle, along the tentacle, you may get hundreds or thousands of nematocytes, and this poison sac has a mechanism that inject the venom into your skin. So when you touch this tail-like tentacle on your skin, this nematocyte will inject the venom the way you can see in this picture, and the venom will act on the system to produce further systemic effect. So the treatment mechanism should have method to remove these nematocytes. So it can be mechanical or maybe chemical. So you can imagine you should not promote further inject of this poison into your system. So whatever method should not aggravate the condition, because sometimes when you touch this tentacle, you may try to wipe it out, so it will worsen the condition. So when you see a person with the jellyfish attack, you may get skin patterns like burn with some hot water. There can be whip-like or ladder-like pattern in the skin, and later if you examine, you get neurological symptoms also. If they touch in the eyes, it may give conjunctivitis. Systemic effect may produce bronchospasm, maybe a vasospasm and arrhythmias. there's a condition called Irukandji syndrome that is caused by jellyfish envenomation. When you go to the beach and you feel nothing, but suddenly you drop with the kind of shock-like condition, because this is a delayed anaphylactic reaction. So it is not reported in Sri Lanka, but it can happen with the tentacles of this box jellyfish. So if you suspect this kind of injury among your patient, he has a history of going to the beach and had a sea bath, how are you going to confirm? You can do several tests. One is a sticky tape method. That means you can take a simple tape and that means apply that tape along the skin area where the burn type injury has occurred. And when you remove it, the tentacles will stick onto this sticky tape, and you can see this tentacle under microscope. And maybe you can have a keratin scraping, or you can confirm the hematological studies to see the anaphylaxis. If there are eye injuries, you can see through slit lamp. Some immunoglobulin methods are available to detect box jellyfish and Portuguese man of war envenomation. So for this kind of jellyfish attack, we should not use normal water. I said we should not aggravate the condition. If we try to use the normal water, the nematocytes will fire further and send further poison into the victim. So better to use normal saline or seawater. That will not change the osmolality of the environment of the tentacle and will not fire further. And also we can use acetic acid. So we can use non-tooth forceps and remove manually. Don't touch, because even they can prick your glove. You can use any kind of analgesic for the pain control. Then you have to manage wound, because marine animal, marine pathogens that mean can produce infection, serious infection, and also you must give the tetanus toxoid, and also we have some antivenom for the box jellyfish, but not in Sri Lanka, mostly in Australia. Then we come the marine animal available in Sri Lanka, stingray. This we call in Sri Lanka Sinhala madua. It usually lie in the sand and buried in the sand. So even they come to the beaches. So if we walk on the beach without any footwear, we may accidentally step upon them. Then they suddenly jerk their tail, and there's a sharp spine. They can insert the spine to our leg go. Maybe some deaths reported by stabbing onto the chest. This stab is very painful, and they can necrose the surrounding muscles also. And the part of the spine can remain inside the wound. So we will have to remove it surgically. Then we have to look after the wound and prevent secondary infection. So as I said, this reaction, that means this poison can be denatured with warm water. So try to immerse the area in warm water and keep it for 30 to 90 minutes. And we can use local anesthesia around that around the wound, maybe Marcaine or lignocaine. Then we can control the pain. And as I said, we should do the surgical debridement unless it will produce severe infection. Here also we can give oral antibiotic and tetanus toxoid. Then we come to the sea snake bites. This is also sea snake available in Sri Lanka, but it is not very common bite among our fishermen because this is very slender and very that means this animal is very fearful to the other people, that is always try to avoid. Even though we have about 15 species male in the northern sea waters, we hardly get deaths from this sea snake bite. But if we have a sea snake bite, it is very deadly because our antivenom do not cover the sea snake bites. Most of that means more than 80 bites are dry bites, and only about 10 bites produce a kind of envenomation, but very rarely deaths. And the envenomation produce neurotoxicity and myotoxicity. So you can see little video. You can see sea snakes are very friendly to move around. They have to come to the surface for the breathing. They have long lungs and can remain in the water for several minutes. So usually larger like the land snake fangs. So very hardly they can make a effective bite. Sometimes their fangs dislodge into the wound. So if you get a patient with a sea snake bite, look for the fangs. You may have to remove the fangs. So the clinical management, the clinical features can be mild confusion, drowsiness, and myalgia, ptosis, oliguria, that means renal failure can happen, respiratory distress. And we can do the investigation for the renal function. And antivenom, as I said, Commonwealth Serum Laboratories antivenom available, but not in Sri Lanka. Then we have to concern about the anaphylaxis. Sometimes we may need to dialyze the patient to save the kidneys. Then we come to the lionfish and stonefish envenomation. Usually, lionfish are very attractive. You can see in this picture, they have like feather-like features. Divers like to go near to them, and the stonefish, they usually buried among the sand area, maybe with the corals. So we accidentally step on these fish. So they have about 13 spikes upon their body. So uh, they have the specific venom gland. So they in the spikes they have the venom gland. There's a mechanism when you prick your skin, then this outer layer will push down and make a pressure on this venom gland. The venom will come out to the wound. So in that way, both this stonefish and lionfish envenomate the prey or victim. So it will produce a severe local reaction and maybe severe pain and produce that mean there's a bluish like skin color change around the injected area. And also there can be tissue necrosis or vesicle formation. You should look for the embedded foreign body and also prevent the secondary infection. There also we should denature the protein with the warm water and pain control with local anesthesia and antibiotic. Then comes the echinoderm envenomation. This is very common even among our divers. Most of us must have experienced this even at least sea urchin spike and injury, but this they do not inject poison, but only the nuisance of the pain. Here we usually try with the vinegar. That is not the best way, because vinegar, even though we expect denaturing of the protein and the part of the spike with the vinegar, it doesn't happen. So here always it must try to remove the part by surgical excision. And this sea cucumber tentacle produce kind of local reaction. Here also they can damage the eyes if we touch on them, and we should remove surgically. Uh, then they produce acute burning type of pain and systemic symptoms due to pain. If they touch on the eye, especially sea cucumbers, produce local ocular inflammation. And sea cucumbers, the these body parts produce kind of dermatitis also. If we do not remove this part of the echinoderms part from our body, it will produce local persisting granuloma-like reaction. I told about this removal. Then conidae envenomation. This is very common if you are going, when we try to handle this conidae. The thing is, we sometimes forget we have had this kind of envenomation, because when we walk around the beach, this conidae can inject the venom to us without our knowledge. Later on only we get the reaction. This animal inject oligopeptide combinations, and it produce erythematous macular-like reaction, erythematous macular reaction. So you can see the mechanism of the envenomation. You can see there's a long tube-like thing come and inject to the fish, and then it's incapacitated, and then it is engulfed. So coordinate in envenomation, mostly on hands. They have small teeth, like that means radula teeth. They can remain in the site of sting. So try to identify them and remove them. They can produce numbness and paresthesia and burning type sensation, and maybe if it is very severe, can lead to respiratory paralysis. The management always try to maintain the airway if it is systemic, and the pain control can be done by warm water applying onto the area. There's a Blu-ray octopus. This is also available in Sri Lankan water. Usually it is brown in color. If they get agitated, they produce these blue rays. So it is very poisonous. They have the mouth underneath of them. Never take Blu-ray octopus onto your hand like this, because underneath they have the mouth and they can bite. And the envenomation is very severe. It can produce death within a few hours. So it has venom that can produce peripheral nerve conduction and also sudden shock. Other last animals usually the biters, moray eel, barracuda, and sharks. Eel and barracuda eels, we usually get the injury by trying to feed them, especially the divers. We have some diver. We have a diver or two, I can remember. He had a degloving injury of the hand by the bite of these eels. And barracuda also is a sharp bite. And you know about the sharks. They produce major bites, but sharks bites are very limited in Sri Lankan waters. So don't afraid of the shark bites when you go to sea in Sri Lankan waters. So with that, I conclude my presentation. Any question we can discuss now or later on?
Now, Dr. Dinesh, thank you very much for your informative and interesting lecture. We are having question and answer session in the after two lecture. We'll go we'll forward with the other lecture. I think now, Dr. Dinesh, can you exit from the slide share? Please. Dr. Heerath, are you ready? Hello.
Yes. Yes,
Now
I'm on it.
Now, are you able to share your screen?
Yes.
Okay. Okay. Now I am cordial. Now I am cordially invited to the Dr. Heerath for second session of our symposium. Yes,
Yeah.
Dr. Heerath, please start your lecture.
I think you can see the slides now.
Yeah. Now we can see. Yeah. Thank you.
Yeah, actually, sorry for the disturbance, for the technical failure. I think the problem is with mine or my technical staff. So thank you very much for giving this opportunity. So I think I'm audible for everyone.
Yes.
Am I audible?
Yes.
Okay, right. Actually, I'm trying to cover a topic very close to my heart within very short time. So first of all, I would like to thank for College of General Practitioners for giving me this opportunity. I would like to line up my speech in under these subtopics. So I would like to discuss the present situation of diving industry in Sri Lanka and brief introduction to diving medicine for knowledge of the doctors who are listening to our presentation, and the primary clinical management at pre-hospital and emergency department level for diving medicine emergencies. So actually the diving as a terminology, the term of the diving explains that desired underwater movements. If it is undesired, the term is sink, not diving, right? And there are several classifications to classify the diving. Those classifications are derived with the technology using for dive, or the diving gases used to dive, or the depth that we are going to achieve, or the purpose of dive. But in the medical point of view, in Sri Lanka, the diving technique, diving gases and depth are almost equal among all the groups. So in a Sri Lankan diving medicine scenario, actually the main difference of the statistically significant classification is the purpose of diving. When we are going to classify the diving operations of the divers according to their purpose, or the why, because of why they are doing diving. So there are three main categories being identified so far as per the agreement. So the first one is the military divers. Actually, the most competent divers are in the military, in basically in the Navy or Army, and including police as well. And but the most majority of divers belongs to commercial divers. Because they are the people who are doing commercially or the profitable diving. So they could be fishing type activities, underwater mining, underwater construction, slip clearance as well. So other the group which linked to the industry of tourism is the recreational divers, the people who dive for recreation or the playful activities. So in majority of divers in Sri Lanka, either commercial divers or recreational divers. So, and the most of the diving illnesses or the diving related emergencies are reported among those two groups, not from the military divers. Right. If you are analyzing, or if you are describing the diving industry of Sri Lanka up to a certain extent, actually it is increasing annually. That is the alarming or whatever the more significant observation, because of the exponential growth of the field of tourism. I'm speaking the pre-COVID era. So diving industry was booming up in an exponential manner, and the most of people also tend to select the commercial diving opportunities because of the high income, and it's also linked with the rapid development of tourism. And actually there are around 300,000 population in Sri Lanka who are dependent on the diving industry directly or indirectly. So you can see the table. Actually, the most of the divers are belongs to recreational, commercial diving categories, and military divers are confined to the well-trained divers in Army, Navy, Air Force, Army, Navy, and Police. And why we are speaking about the special or whatever the special topic of this diving medicine or diving and hyperbaric medicine is that because when you are going deep into the water, the ambient or the environmental pressure increases with the water level. It is common to water or air. If you dive in a air or water filled environment, when you go deep or towards the bottom, the weight of the water or the air column over your body is increasing with the depth. So as you can see in this table, so when you go 10 meters deeper, so ambient pressure will increase in two-folds. So likewise, when you go down, your ambient pressure is increasing. So the increased pressure will affect the body surface as well as internal organs, and there's a separate pathophysiological effects will create inside the body. So that is the basic of diving medicine. So actually, first this, if we are going to history, first this diving medicine or the hyperbaric medicine is introduced or identified in related to the caisson workers. Caisson workers are the people who work in underwater environment, especially for the requirement also building this type of large bridges. So the caisson is the sort of equipment that, or whatever the structure that if you want to reach the underwater or the bottom of some reservoir or some river, what you can do is you can make a closed compartment from surroundings and you can pressurize that particular compartment. So water will get displaced and the environment will be remain with compressed air. So the people can go down through this compartment and start working on the bottom. So this type of structure we call caisson. So in that type of structure, the workers will always get exposed to high ambient pressure. So once they come out, so there are certain the typical clinical entities developed among those patients. So they first described this as a caisson disease, and the first they called it bends. So that's how the diving medicine is evolved. And there are different terminologies in medical field to describe this subspecialty, including underwater medicine, diving medicine, and marine medicine. But basically, more or less, the concepts are equal, right? And why divers face to the diving related illnesses? That is, sometimes though they have planned to do some specific diving activity or some they want to reach some depth, but because of some accident they have to surface all of a sudden. And sometimes there are some failures observed in the equipments which they use for dive. And other thing is, some divers, if they are not well trained, they are not aware of how they go down or how they come out. So so that type of incidents are categorized as technical failure. Or sometimes the people who assist for their dive, they are not competent enough for the proper diving as a proper diving assistant. And even though all the factors are in a optimal manner, there are some adverse environmental factors are expected in any time because of that water level or the water waves or as described in the previous presentation, the hazardous marine animal or similar because of similar events. Right. And in diving hyperbaric and hyperbaric medicine or the diving medicine, we have identified several clinical entities. So, so these are the most commonest clinical entities: barotrauma. Barotrauma are the traumas which we are susceptible because of increased ambient pressure. So most commonly, the airfield cavities are more vulnerable to develop barotraumas. And other thing is the toxic effects of the gas. As per the table I showed a little while ago, when you are going underwater, you have to breathe the breathing gas in the same pressure, otherwise your lung will collapse because of the ambient pressure. So so as the diver has to be breathe the breathing gas in the same pressure which pressurized in the container. So what happens if the pressure of the gas is increasing, partial pressure is also increasing. So likewise, a diver can subject to various toxic effects because sometimes those partial pressure is the beyond the level that we can tolerate physiologically. And the main or the most debilitating or the most morbid and morbid illness, morbid and type of illness is the decompression sickness, because the decompression sickness will give rise sometimes the more permanent neurological deficiencies of divers unless we treat it promptly. And there are rare clinical entities like high pressure neurological syndromes, which not very commonly found in our countries. This is very common with helium and other mixed gas diving, and dysbaric osteonecrosis for the divers who are doing diving for a long duration. And if we look into a barotrauma, the barotrauma is either squeeze or burst. You can see that if air-filled cavities of body is always susceptible for external pressure to collapse or to burst. If external pressure is more and the air-filled cavity pressure is low, so it will squeeze. and it can cause barotrauma. Or in the other way around, if you go down your sinus or whatever, your middle ear, which is filled with more pressurized air, and when you go up, if that air or whatever that space, entrapped air cannot escape, so it will burst like a balloon. It is like sending balloon up. And these are the common clinical entities. It could be a pulmonary barotrauma or the ear barotrauma or sinus barotrauma, other type of barotrauma, which is common to any sort of air-filled cavities of the body. And the toxic effects of the gas, as I explained, it is also a very common entity in diving medicine. But in Sri Lanka, most of the time, our depth is very low compared to the other countries. So that gas toxicity is not that frequently experienced in Sri Lanka. Sri Lankan divers. And as I explained, the most of the instance, the divers come with a decompression sickness, which is most dangerous type of diving illnesses, which give rise permanent neurological deficits unless you treat properly. So the etiology of that diving, these clinical entities, that in your breathing gas, there are certain gas types are inert because you can't absorb that gas or you can utilize this gas. As an example, nitrogen or helium. So those inert gases, what happened when you go down, the pressure of that gas is increasing. So with the Boyle law, the more and more gas will dissolve in the human body tissues. So once you go up, gradually this gas will clear back from your lungs by exhaling. So if your ascent is not that controlled, or you ascend all of a sudden for some purpose, or if you spend more time in the bottom, that the remaining gas in your bottle is not adequate for a safe or the controlled ascent, what the diver do is he will ascend in a quick manner. So what happened when you go up, the amount of inert gas has to be released to your lungs. But unfortunately, that particular diver, unless he has given a certain time interval in certain depths, or unless he ascend in a slow manner, the time interval he is sparing is not adequate to clear that particular inert gases. So what will happen if you go further up, for that particular pressure, the volume of gas that we can remain in the bloodstream or the tissue as liquid is exceeding, or the threshold has passed. So that particular amount of gas will form a bubble inside the tissue. So this is the basic etiology of decompression sickness. So, and then most of the tissues develop clinical symptoms because of hypoxic events, which affected through those bubbles. Either bubble could be in the small capillaries, or it could be adjacent to the vital tissue cells, cells of the vital tissues. So basically it will develop hypoxia. So those tissues, if it is a neurological tissue, because of that hypoxia, it is present as neurological deficit. So that is the basic pathophysiology of decompression sickness. And usually it onset within minutes or hours after ascent. So, and the other type of pathophysiology or the other etiology of gas formation is the barotrauma to lungs. If your lung is damaged, it can pass the gas bubbles to the microcapillaries, and through the pulmonary vein, it can come to the heart and disseminated through your body organs. So both way, even though the mechanism is different, the pathophysiology or the tissue level function is almost equal. And this entity we call arterial gas embolism, and the other thing we call decompression sickness. Both way will need will affect to the body in a similar pathophysiological way of tissue hypoxia and tissue inflammation, but the mechanism of gas bubble formation is different. And in the DCS, or the decompression sickness, there are main two types. One is type 2 DCS, which gives rise neurological manifestation. Other one is the type 1 DCS, is basically give the manifestation of muscles, joints, pain, likewise. And this is the way that gas bubble damages the body tissue. It could rupture a cell, rupture a cell because the gas bubble is expanding inside the cell. or it could rupture a blood vessel, or it could activate the intravascular coagulation, or it could cause direct hypoxia, or it could activate the inflammatory cascade. So these are the symptomatology because of the decompression illness. So you can see the most of the time the people or the divers presented with localized pain, but rarely they presented with paralysis or the neurological deficits. But however, these symptoms could be multiplied. As an example, the person first presented with localized pain, and it can propagate up to the level of numbness, paresthesia, then up to the muscle weakness and paralysis. So we have to be very careful in that instance, because we should not disregard any suggestive symptoms of decompression illness if diver reported us following a dive. And if we go through the statistics available with regard to the diving related illness in Sri Lanka, we can see that actually we have experienced several number of deaths so far. And if you go to the 2020, you can see the number of diving related illnesses are increasing. These are the figures presented to Diving Medical Center of Sri Lanka Navy. But there are a lot of cases, I suppose mild cases, they remain at home or they go on for some other remedies without coming to us. So those statistics actually not with us. And what is the treatment available for this life-threatening or the long-term the disease, this type of long-term complication or the neurological deficit? That is the only treatment option available is recompression treatment. That means we have to take back the patient as soon as possible to the high ambient pressure. Then what will happen? Those gas bubbles form inside the tissue, they will dissolve again inside the tissue. And gradually, if we take up the patient back from deeper, that means high ambient pressure to the normal airway pressure. So what will happen? Those gas bubbles will exhale through the lungs in a gradual manner. So there are so much adjuvant treatment modalities as well with support to that recompression treatment. So, but this is the basic principle of treating decompression illnesses. And on top of this, dissolved in gas bubble bags, the increased ambient pressure itself have some other effects as well. That is minimizing the inflammation because of oxygen you inhale while you are in a high ambient pressure, and always it minimizes the reperfusion injury as well. And this is the sort of chamber or whatever the device or the equipment you use for recompress the patient who develop decompression illnesses. So this is at present we have only one chamber available in Sri Lanka, which is situated in Diving Medicine Center in Trincomalee Naval Dockyard. So this is very valuable equipment. The cost is around more than 600 million rupees. Because of the higher cost and the more technical demand, Sri Lanka couldn't achieve its second chamber, which we have suggested to locate in a western coast, I think more than 5 or 6 years so far. So this is the way they put the patient inside, and you can see the air banks which used to pressurize the chamber. So, and this is the inside the chamber. We can accommodate nearly 10 mans in a seated position in this chamber, and we can use a separate breathing apparatus like this to let them breathe in pure oxygen or normal air. So this is a control panel of this chamber. So this chamber is we call RCC, or the recompression chamber. And this is the certain treatment table. So the treatment modules we use to treat such patients. So you can see the axis has showing the time. So these are the time interval, and the y-axis we showing the depth. So the feet FSW means feet seawater. So this is the level that we enter the chamber, and we increase the chamber pressure up to equal level up to the depth of the sea. That means the feet seawater. So here in this table we go up to 60 feet seawater, under seawater. So this whole table will take nearly 285 minutes to complete this cycle. So in this way, we are going to treat that patient who are having decompression illness to become normal. So in the treatment of decompression, if we consider this, so majority of the diving patients who are doing diving are otherwise healthy or relatively young people. And at their maximum productive age, you can see the old people doesn't select such a job which endanger their lives. So they are very capacitated and very brave young people. And if you lost one person, and if one patient ended up with in lifelong neurological deficit, it is very huge loss to country as well. But our observation is somewhat arbitrary. Most of the diving patients received by us for recompression, either they presented delay after spending 24 hours or more than that in some other centers, so properly not referred properly or not properly transferred to our center. So this is very unfortunate finding, which we have to improve as much as possible. So these are the reasons with lack of awareness about the diving illnesses. So far, even though Sri Lanka is surrounded by sea, no curriculum is given any priority for this specialty or this entity of the medicine. So, and the only one recompression chamber is available. So patient who develop diving illness from Western Coast, he has to come to the Eastern Coast on the way 256, more than 256 kilometers to get his recompression treatment. And actually, I just wanted to, that is basically about the diving medicine or the decompression illness and the way we are going to give the definitive care. But there are a lot of things that you can do at your levels. So these are the levels that we can manage diving medical emergency with a consultation of professional competent clinicians who are presently in the Navy or maybe in outside. So there are several levels we have identified these lapses, identified lapses. So we just wanted to improve those levels in a primary care management. So first one is the pre-hospital care or the first aid. Second one is the emergency department of the any hospital. And third one is the transport protocol, transferring protocol of the diving emergency. And the definitive care is job of the diving physicians. So the first thing you have to do is in the pre-hospital care, whenever a person reported you about diving incident, you let them speak to Sri Lanka Navy help desk. So I will come forward with the telephone numbers, because once Sri Lanka Navy came to know about the diving patient, we are going to track that person continuously till the time that patient reported to our diving medical center. So that is very important. And in the field, the first aid you can provide is oxygen and limb elevation. And soon you have to transfer the patient to nearest hospital rather than trying to take that particular patient or the transfer that particular patient by available means to the diving medical center. This is a very important message, because for the optimization is very important on the way trans. Otherwise, what will happen? Patient develop is more complication during the transfer, and he will end up in the diving medical center as a patient that we can't take him to chamber straight away. So always you have to take the patient to accident and emergency department of the local hospital, then optimize and then transfer. That is a very important message I want to convey. And in the accident and emergency department, the first of all, the most important thing is that physician or the doctor or the emergency physician has to contact Sri Lanka Navy help desk. Even the relations or the first aid group has contacted the Sri Lanka Navy. The contact through the doctor is very important, because with that conversation or with that communication, we can come to a conclusion of the patient with the clinical assessment and other parameters. And the second thing, more important thing, is a proper assessment of the patient. We have to tentatively diagnose that particular patient is having diving illness. Otherwise, what will happen? The patient may be having some other illnesses, or there are clinical evidences of other illnesses which you misleaded because of the diving history, and on the way transfer, patient will develop some other complication which cannot be treated in the diving medical center. So that is also very important. And the third one is assessment of the severity of the illness. That is very important, because of the severity, we decide how quick we should be to give that particular patient recompression treatment. So that is also very important. And the first line emergency management. Right. So how you tentatively diagnosis and assess a diving medical emergency. So the foremost important thing is if the patient carries a history of diving or the exposure to hyperbaric environment because of some other activities which I explained earlier, as an example, the case and work, still those type of construction or the activities are going on in the field of construction. So you have to take into mind, unless proven otherwise, this could be a diving related emergency, right? And the time duration, basically we considered the last 24 to 48 hours. Even you can go up to 72 hours because there's a reported cases, even after 4 or 5 days, they develop decompression type of illnesses or other diving related illnesses after last dive. And the second thing is, if such case is presented with associated history or symptoms suggestive of neurological deficit, that is more or less diagnostic of diving related illness. And there are a certain set of symptoms or the category of symptoms if we consider the diving related illnesses, and most of the time the decompression sickness. The non-specific symptoms are considered as lethargy, nausea or headache. These are very common. These are the more commonest symptoms reported by divers because they are suspecting that they are having decompression illness, but because of some other reason, they develop some lethargy, nausea or headache. And the categories here, two symptoms or the somewhat suggestive symptoms are subcutaneous swelling, muscular, the commonest symptom is a musculoskeletal pain and rash and paresthesia. And the category 3 or the major symptoms, which most of the time strongly suggestive of decompression illnesses, are change of consciousness, dysarthria, visual disturbances, unsteady gait, sensory loss, motor weaknesses, or most of the patient presented with bladder dysfunction, urine incontinence or overflow incontinence, or sphincter dysfunction, and sometimes shortness of breathing and the extremity pain, and even sometimes abdominal pain and distension because of neurological secondary neurological events. And as you can see this, the most of the time patient develops some vague or the non-specific symptoms, but very rarely they come with the straightforward symptoms. But however, with the history of positive diving history, you have to always suspect diving emergency first. And how you approach for such patient, that this is very important. Your correct approach will save his life and save him from lifetime neurological deficit or some other debilitation. And this is the first approach, and this is the first management, and this is the first plan. So if you go to the first approach, as all other emergencies, you should address the airway, breathing and circulation. And in such situation, you have to keep in mind the diving patient are always likely to develop pulmonary barotrauma. So in associated, you will observe pneumothorax. So reduced air entry may be secondary to pneumothorax, or the sinus or ear barotrauma, which you can see as a blood-stained mucus or bleeding through the orifices. So in such situation, you have to always keep in your mind that that is secondary to barotrauma or some complication of diving. So in such situation, same time patient can have double pathology. As an example, he may have pulmonary barotrauma and decompression illness as well. So, and the disability is very important. Once you assure the patient's airway and breathing, you have to check the level of consciousness and the weakness of breathing. If patient doesn't showing any other signs, if you check his motor weakness, or it is obvious that patient is having motor weakness with associated diving history, it is actually more or less diagnostic as a diving related illnesses and decompression sickness. And the sensory impairment, or sometimes most of the patient, even though they don't have any motor weakness, they will come out as a cerebellar signs or dysarthria or the visual disturbance, because neurological tissues are the most vulnerable affected tissue because of this hypoxic etiology. So once you develop decompression illness, the more clinical signs could be localized pain or the secondary to the bubbles or whatever the things you develop in your extremities, but it will propagate sooner or later to the level of your neurological tissue. So that is very important. Keep that in mind. And exposure is also very important. You can see some other signs which are common to the decompression illness, especially the type 2. It is the cutaneous type swelling because of air bubbles develop in the level of skin, and sometimes subcutaneous emphysema because of the pneumothorax or secondary to pulmonary burst. And some the rashes also very common in the Western or the fair skin people, but I haven't observed that sign in Sri Lankans in such a distinct manner. And sometimes this is secondary to dangerous marine animal bite or some animal attack. So you have to be careful to examine the patient to see the bite or sting marks. And because of this COVID scenario, I would be like to recommend doing rapid antigen test or PCR, or get a PCR sample at this time, because we have separate protocol for COVID positive patients and COVID suspected patient with regard to recompression. So you have to always think about the positivity or the risk of the COVID status of the patient. It would be much easier to handle us to that case in diving medical center. And other differential diagnosis, always you have to keep in mind, even though beside that is diving history, it could be some other pathology. As an example, could be a case of drowning. And as the previous presenter said, his clinical presentation could be secondary to venomous marine animal attack, as a sea snake or some other venomous marine animal which cause paralyzing and severe neurological findings or the signs. And the nitrogen narcosis is another phenomenon. As I said earlier, when you inhale normal gas in very deep level, then the level of nitrogen or the partial pressure of nitrogen is increasing in a level that your body cannot tolerate it, because as you know, as a medical officers, we all know that nitrogen can develop some narcotic events. So if diver has gone very deep level with using nitrogen or the same air, say compressed air, he may susceptible to develop nitrogen narcosis. So he will come out as a with the symptoms of drowsiness or impaired mental status. So you have to keep that in mind always. And other than that, the anaphylaxis and some divers with history of diabetes, because diving is very strenuous exercise. If you go down with hypoglycemic drug, it is very prone to develop hypoglycemia. So you have to always think about that aspect as well in one point of your differential diagnosis. And what is the management you have to do for that diving medical emergency? Actually, it is life-saving management is life-saving definitive treatment is recompression treatment at the recompression chamber, as I explained earlier. But you can do very important supportive management at your level. So that is, first thing is you have to put that patient in 100% oxygen in this minimum 6 liters per minute, and you have to hydrate the diver, because when you are giving 100% oxygen, the excretion of the gas, inert gas bubble through your lung is exaggerated. So that will give a quick relief to diver. In some occasions, we have observed with 100% oxygen, diver has recovered up to certain extent. Another thing is hydration. When the usually diving is very dehydrating job and very strenuous exercise, and if when the diver is dehydrated, the effect of decompression illness is very high, because you have to have very good perfusion to clear those bubbles out of your vital tissue. So you have to hydrate the diver in very promptly and very correct manner. And positioning is also very important, because as I show you, if you position a diver like this, whatever the air bubble forms in his bloodstream will ascend through the bloodstream to non-vital part of the body. So in case those air bubbles will not ascend to the level of brain or neurological tissue, because in this position, your vital neurological tissues are the most dependent. And the non-vital muscles and the lower leg tissues are kept in the level in higher to that vital tissue. So in such situation, whatever the gas bubble will ascend through your bloodstream to the non-vital part of the body. So this position is very important during the transfer and during the management at the accident and emergency departments. And this is the oxygen and this is hydration. And there's a very important point. If you are going to transfer the patient, you should not give oral, because during transfer, patient may develop a lot of complications like nausea, vomiting, because of secondary to neurological manifestation of decompression illness. So best thing is to start him on IV if you are planning to transfer him immediately. And you have to calculate the fluid with loss and maintenance, and you have to supplement the fluid preferably with crystalloids. And always we have to think about hypothermia, because diving itself is a job that a lot of heat will be conducted out of the body. So hypothermia will increase or will adversely affect his condition. So always you have to make the patients, remove the patient's wet cloth and make him warm. And the next important point is, what is your plan, right? Always, as a general practitioner or a accident and emergency physician or a consultant who doesn't have a facility to manage diving and hyperbaric related emergency, the ideal management is to optimize the patient and transfer the patient in case you found category 2 or 3 symptoms, as I explained earlier, basically the neurological related symptoms. And that has to be arranged in very prompt manner, because the studies have shown the recovery is more than 90% if we transfer the patient, or if we offer the recompression treatment to the patient in first 6 hours. And emergency management, as I said, the oxygen and positioning and hydration should be continued during the transfer. And always it is preferable to transfer the patient in an ambulance, not the vehicle of that poor patient, or they brought the vehicle, they are going to bring a van or something. The ambulance is always you have to provide with the support of medical officer, because you have to anticipate a lot of complication on the way transfer, because it is very lengthy transfer. Nearly it will take 6 or 7 hours. And if category symptoms, category one type of symptoms with a diving history, you can watch and wait with the consultation of diving physician of Sri Lanka Navy or some other location. Because in such situation, you are not very sure whether patient is having diving related illness or some other sort of illness. So you can watch and wait, and you can observe the patient, and in case if it indicate or the propagate the cascade of symptoms, you can decide about the transportation. And these are the special consideration. Without further delay, you have to always exclude pneumothorax if suspected. That means the patient is having low air entry, and clinically if it is pneumothorax, before transfer you have to address that issue, otherwise it will be killing the patient. And second thing is very important thing, which frequently missed by primary care physicians while handling diving related illnesses, are they forgot about the requirement of urinary diversion. Because on the way transfer to diving medical center, if patient develop urinary retention, you have to go and stop somewhere else. The best thing you can do is, if the doctor is going with the patient, if he is competent enough to at least do suprapubic tap, you can give him the equipment which required for suprapubic tap, just with the large bore needle. That would be enough till the time you report to diving medical center. No point in delaying a patient because of urinary retention without sending to diving medical center. If patient is having symptoms of urinary retention at the primary care level or accident and emergency department, the best thing you can do is put a catheter in safe manner, sterile manner, and transfer the patient. And the third thing you should not forget is always think about the ECG finding and blood sugar levels, because this is one observation which I made during my experience during last 5 or 6 years, nearly 10 years. Some patients, once they report to us, they are very hypoglycemic, or sometimes the ischemic pain could be very atypical. So those divers may develop some ischemic myocardial ischemic events and presented as a diving emergency. And what are the take-home message of my presentation? Actually, diving incidents in Sri Lanka, and not only Sri Lanka, in overseas, are increasing. Number of diving incidents are increasing. And diving patients only need your immediate attention, simple emergency management, and urgent transfer to diving management center for full recovery. And in Sri Lanka, the parallel development of diving medicine field is not observed so far because of various reasons. And the most identified reasons are the highest cost for recompression chamber and lowest potential for profitability and minimal public interest. And other thing is, as common to most of other deficient area, it is a policy-wise, we are very deficient. Even though we are a country with ample resources related to marine economy and marine environment, we are very lethargic to think about or improve such industry. And these are the diving medical center contact details. You can come, you can always call through the Navy headquarters telephone lines, whatever telephone lines. If you ask for, if you can declare that I am having diving emergency, I just wanted to contact somebody, they will directly connect to suitable person. And either the other way, one of other way is you can contact a diving physician through Navy Hospital, Trincomalee, or Diving Medical Center, Trincomalee, straight away. Right. Thank you very much. And sorry for the inconvenience because of the technical failure.
Thank you very much, Dr. Hearth, for the interesting and informative lecture. Now we are moving for question and answer session. First question I will direct to the Dr. Dinesh Ariyadewa. This question raised by the Dr. Malik Fernando. He is asking the blue ridge octopus only available in Australia, not in Sri Lanka. Yeah, Dr. Dinesh.
Yes, Dr. Malik Fernando is a very experienced diver, and he is still engaged in the diving activities. So his experience, he said, but I have not seen, but I have read in the articles that it is available. He must be correct. But internationally, I was speaking about the medical condition. The venomous condition is the same as I mentioned. The availability I have seen in the articles, but if he says, he must be saying with his experience.
Okay, thank you, Dr. Dinesh. My next question for Dr. Hearth. Dr. Hearth, as you told, many diving accidents in the Sri Lanka are reporting among the younger crowd. That means they are, what is the reason for their more vulnerability for the diving accident, or do elderly population are not engaged in the diving accidents, not engaged in the diving activities?
Yeah, actually, basically it is like this. With my experience, clinical experience, if younger people, the first of all, I would like to explain that in Sri Lanka, we don't have a special or recognized or organized training program for divers. What they do, like in a fishermen, they go with their elderly brother or their father, and they learn diving with the experience. So in certain situation, and most of the diving casualties or the diving injuries are observed among commercial divers. Basically, in commercial diving field, Sri Lanka, they are doing ornament fishing or collection of some valuables in the seabed likewise. So in such situation, the younger crowds are more tend to, because of less experience, they are more tend to forget about the risk. But elders divers, they have more experience, so they always have focused on the risk of ascent or the amount of remaining gas inside their tanks, or the visibility of the water, rather than giving priority for the profit that they are going to get from the particular dive. So that may be, I think, reasonable for as an answer for such question. But actually speaking, the number of divers who are below 40 years of age are much higher than the number of divers who are above 40 years or that is the second observation supportive to my answer.
Okay, thank you, Dr. Herat. It seems no more questions. Then I'm going to conclude the session. At the concluding of today's webinar, we have come to very interesting 1.5 hour sessions. I would thank everybody who are involved. So first I would like to thank to our speakers today, Dr. Herat and Dr. Ariyadewa, for all your contribution. Thank you very much for the interesting, informative and timely presentation. It was great to have you here. Your time is very much appreciated. Then I would like to thank Command of the Navy and Director General Health Services of the Sri Lanka Navy for accepting our invitation and provide expert resource personnel from the Medical Department of Sri Lanka Navy and giving permission to conduct this webinar. Then I sincerely thank to President of College of General Practitioners, Dr. N.L Matthew, and Secretary of the College, Dr. N.L Ulluvisheva, and Dr. Shobhavi, who is the chairperson of CPD subcommittee of the college, for all the support given at all times. It is really encouraging to see that we had a lot of participants today. It is around about 45. So it is very much encouraging. Thank you very much, all of you, for presence. We would like to see you again in another future program. Finally, I would like to thank for our dedicated college staff, Ms. Dimutu, and her team for smooth functioning of the meeting without any technical issues. I think we can conclude the session now. Have a pleasant evening, all of you. Thank you. Okay, thank you.